In this lecture on mental health disorders, we're going to look at somatoform disorders, such as somatization disorder, conversion disorder, hypochondriasis, pain disorder, and body dysmorphic disorder. And then we'll look at factitious disorder and malingering, and then personality disorders, cluster A, B, and C, and eating disorders. So we have a lot to cover in this one. So we'll start with somatoform disorders. The definition is basically this is characterized by physical symptoms that occur in the absence of any identifiable physical pathology, and the patient is not intentionally causing or thinking they have these disorders. So this is not being intentionally exhibited by the patient. Thought to be an unconscious expression of unacceptable feelings. So there is an emotional component manifesting through the physiology, but the patient is not intentionally trying to deceive anyone in thinking that they have this condition. Although social factors may bring on the symptoms, the patients believe their symptoms are medical in nature, and there are primary and secondary gains associated with the symptoms. But patients are often unaware of this. So this is more prevalent in females, except for hypochondriasis disorder. And it's estimated that up to 30% of all primary care visits for somatic complaints may actually be attributed to somatoform disorders. So this is not uncommon in patients coming to adjunctive care practices. Now, again, in a biomedical sense, there's often this dualism between the mind, the psyche, and the body. And we have to really think there's a continuum there. So what manifests in the body as a somatic complaint, as for example, an organ dysfunction or digestive dysfunction or even hypertension or so forth, in almost all cases has a psychological component. And so if we look at it more as a continuum, then this makes a lot more sense. But this is obviously difficult in a biomedical thinking to compartmentalize. By definition, somatization disorder are patients who have numerous doctor visits complaining of multiple and recurrent physical symptoms that affect activities of daily living. The physical symptoms are related to multiple organ systems, but they have no underlying pathology. So they've gone through all these tests, they have all these labs, and one of the things I see happen is instead of the focus maybe being placed more on addressing the psychological issues, they just chase, the doctors go from one doctor to another, one specialist to another, and they get usually hundreds, thousands of dollars of testing and all of this, and they keep thinking there's a medical reason for why they are ill, when in reality we may need to just help them step back and look at maybe the whole framework of their psyche and so forth and how that relates to this. It is important clinically, when patients present, that we do our due diligence. So as a primary care physician, I'm always looking at, ruling out potential medical causes. So we do the full lab workup and whatnot. But when all those diagnoses, those differentials have been exhausted, and we know there are no red flag symptoms, and this is something that doesn't have a real identifiable medical cause, then I think the emphasis should be placed more on let's look towards more the psyche, or address functionally the organ processes, because that can result in improvement in the psyche. This can be chronic and lifelong, and the symptoms often worsen when there's exposure to specific stressors. Females have a 5 to 20 times greater risk of developing somatization disorders than males, and there's a greater prevalence in lower socioeconomic groups. There's often a higher incidence of somatization disorder in different ethnic populations. I work with a fair number of Hispanic populations and patients, and they often there's very interesting similar neurological presentations, which when we do our workups and testing, we don't find any identifiable neurological reason, and there's actually it would be impossible for a specific lesion to account for all their symptoms. But it's interesting how commonly reported some of those symptoms are between my different patients. And so, I looked into the research, and there is an increase in somatization disorder diagnoses in patients from South America, for example. So that's something to always think about as well, is whether or not there's maybe a cultural component there too. The diagnostic criteria, according to DSM-5, are at least 2 GI symptoms, 1 neurological symptom like numbness or tingling or muscle weakness, and 1 symptom that is sexual or related to the reproductive system. That could be menstrual, but also related to sex drive or so forth. And then 4 pain symptoms. So patients have pain in different areas, maybe headaches, and they have muscle pain, they have the pain in their legs, and so forth. The onset is usually before the age of 30, and again, it's important to rule out any potential organic causes as to why they might be having this. The treatment really is, again, based on psychosocial therapy. Pharmacologic therapy is usually not indicated, but again, this is where in the therapeutic order I would address levels 1 through 3. And again, working with organ functions and the connections of the organs with the psyche, that might very well result in improvement. So that's somatization disorder. Conversion disorder is where patients have either a sensory or motor symptom, most often affecting the sensory system of voluntary muscles that are suggestive of a neurological deficit. So the neurological symptoms would include blindness, paralysis, paresthesia, pseudoseizures, mutism, globus hystericus. They may appear to have an inappropriate lack of concern regarding their symptoms. They seem indifferent to their symptoms. And their assessment and physical exam are negative for any organic pathology. Onset of symptoms usually brought on by psychological stressors, and this again affects females more commonly than males. And it's more common in people low social economic status, uneducated young adults, and people that doctor shop. So that's always something I often see, and I have a couple of patients who tend to go from one provider to another in a large clinic like we have at NUNM, but they often go from one health system to another looking for the answer physically, when in reality the answer might be more functional or more subtle in the psyche. Symptoms can appear at any age, but they are most common in adolescence or early adulthood. And so the criteria here are one or more neurologic symptoms that can't be explained medically, identifiable psychological stressors that precede any onset of symptoms. Symptoms are not intentional, and daily living is severely impaired by the symptoms, and the symptoms are not caused by other medical disorders. Most patients recover over time, and again, reassurance is often the main strategy we use. But relaxation therapy, hypnosis, that sort of thing might be helpful. Again, pharmacologic therapy not indicated. So we can think of conversion disorder as more patients with specific neurological deficits versus somatization is more general, neurologic, GI, reproductive, etc. In hypochondriasis, patients have a constant and exaggerated concern that they have a serious disease. Normal physical findings, they often interpret to be a sign of disease. So I have patients when, for example, when we do standard labs, maybe they're just a little bit above or below a certain normal range, which based on the context of their overall physiology is not significant. They become very concerned, and they often, I've seen they actually go to other doctors sometimes to ask what their opinion is, and so on and so forth. So that's one characteristic symptom there. They often are doctor hopping, so they're trying to get one medical opinion after another. Important to note that in OCD patients, they may worry about developing a serious illness, not that they already have it. So in the hypochondriasis, they think they actually have an illness, versus an OCD, they worry about getting an illness. Men and women are equally affected with hypochondriasis, and patients often suffer from major depressive disorder up to 98%, or anxiety disorders up to 70%, or psychotic disorders 30%. The criteria here are constant and exaggerated concern about a serious illness. The concern persists despite a normal medical evaluation and reassurance, and the symptoms are present for more than 6 months. No cure. Patient usually is resistant to mental health consults and referrals to psychiatrists, etc. So this is where often we just use a strategy of reassurance. I think, again, talking about the organ processes as in a more functional way can be helpful, and that gives them something to focus on, and that we can kind of direct treatments in that direction. Pain disorder is patients complain of severe pain that can't be easily explained medically. The onset of pain occurs suddenly, increases in severity in the first few months. We define acute pain disorders less than 6 months, chronic more than 6 months. More common in females, and the average age of onset is midlife, 30 to 50. Patients often suffer from major depressive disorder, anxiety disorder, or substance abuse. And we have here diagnostic criteria: pain at one or more sites, can't be explained medically, causes great distress in the patient, and it's associated with psychological factors and stressors. So it's difficult, sometimes to really take the patient's word. The pain is a subjective feeling, and does it correlate with any objective findings? And that's not always relatable. So a patient might have low back pain, but there's no evidence medically of any nerve compression or anything, but that doesn't mean they don't have pain. And so this is something they are really experiencing. Again, if we think more functionally, talk about concepts such as blockage of the normal electrical flow or chi flow in the tissues, or poor circulation in different tissues that might trigger pain. That's something I can talk about with those patients and give them, again, a little bit of a strategy to work with that, as opposed to further testing, further evaluation, etc. And I've had several patients that have improved tremendously just by having those kind of discussions. Again here, relaxation therapy, hypnosis psychotherapy, sometimes SSRIs are prescribed, and you can actually use nerve stimulation, for example, electrocurrent, microcurrent, things like that. Sometimes that can help with the pain. So this is fairly common, and this is really difficult again to differentiate between, is this more related to psychological factors, or is it more physiologic? Again, if we take a more integrated approach, you have to say they always both go together. And so the important thing to decide is, where do we need to make the intervention right now clinically? Finally, I mentioned earlier body dysmorphic disorder under obsessive compulsive. This is an obsession with the perceived imperfection of a body part, and the patient feels very self-conscious about perceived minor bodily defects. They spend a lot of time, energy, and money trying to correct the perceived defect, like a lot of makeup, plastic surgery, Botox, etc. And this is more common in females. Often there's a social component to this as well. The criteria are an obsession about a perceived flaw in a body part that causes great distress, and the activities of daily living are severely affected. So again, potentially hypnosis, psychotherapy, SSRIs such as the fluoxetine, Prozac are commonly prescribed for BDD. Here too, we can maybe help the patient with different meditative techniques, maybe different biographic techniques, to kind of work at helping them realize that the physical body is just one expression of the spirit. And we can sort of orient maybe the attention more to inner cultivation and so forth, and this connection with inner beauty is then going to be reflected in the outer beauty. So that's a strategy I've used with some of my patients with BDD. Now the next set of disorders here are factitious disorders and malingering. They're related to the somatoform disorders in that a known medical condition can't be identified to explain the patient's symptoms. But unlike somatoform disorders, the patients are consciously mimicking physical symptoms for purposes of either primary, and that's in factitious disorder, or secondary, that's malingering gain. So primary gain really means that they have positive internal motivations, psychological gain, so such as the patient feels guilty about performing a task, but there's a medical condition justifying this inability, and so the guilt diminishes. So that's primary gain, so they try to avoid a behavior based on their medical condition. Secondary gain is positive external motivations or tangible gain, such as if a patient is allowed to miss work or gets financial compensation as a result of a medical condition. So they feign a headache in order to leave work, etc. So that's primary versus secondary gain. But again, the difference here is that they are consciously mimicking the physical symptoms. So factitious disorder, the patients deliberately or consciously produce a medical or psychological symptom in order to assume a sick role, and that's the primary gain. Higher incidence in males and healthcare workers, interestingly. Most common symptoms would be hallucinations, depression, abdominal pain, seizures, hematuria. And some patients actually have a history of child abuse or neglect. We think that's maybe where some of this stems from. They feel like they need to play the sick role in order to be in a comforting and a safe environment, such as a hospital. So they sometimes will feign being ill, be hospitalized, and they get the kind of care and support that they need around them. There's a version of this is called Munchausen syndrome. It's a form of factitious disorder predominated by physical symptoms. The patients have a very specific demands. They need very specific medication. So I have these symptoms. This is happening. I need this medication specifically. They're very experienced at producing certain symptoms. So, for example, mixing feces and urine to fake a urinary tract infection, etc. So that would be Munchausen syndrome. Munchausen by proxy would be symptoms are deliberately produced in another person, and that's typically a child. So the mother might produce certain symptoms or take the child to the doctor saying the child has these different symptoms. For example, urinary tract infection, and then she does something to contaminate the sample, and the doctor diagnoses the child with a UTI. This is considered a form of abuse, although the motivation for the abuse is very unconscious to the patient. So that's Munchausen by proxy. So the criteria for this is the patient presents with a medical or psychological disorder that was again deliberately produced with the intention of assuming a sick role, and there's no cleared external reward, monetary or otherwise. There is no treatment for this, and the important thing is that these patients will often demand a lot of extra testing or whatnot, and we have to be careful about over-ordering those kinds of things. So this can be very difficult to treat. I've had 2 patients that we ended up diagnosing. There was children brought in by their mothers. We diagnosed Munchausen by proxy, and we had to contact social services, and it turns out this one patient in particular had done this at numerous doctors' offices, and she actually had a whole case file opened on her, and they were following her and so forth. So this is something to be aware of. Another type of disorder here, factitious disorder, this is malingering. The patients intentionally produce physical or psychological symptoms for secondary external gains. So as a complaint, they complain of vague symptoms that only improve after they've achieved their desired purpose. This one's more common in males than females. So there's an intentional production of a false or grossly exaggerated physical or psychological problem. The motivation is usually external. So like avoiding military duty or work, or obtaining financial compensation, evading criminal prosecution, or obtaining drugs. All of that would be part of malingering. So again, with factitious disorder and malingering, we have to realize the patient is consciously producing these symptoms in order to have either primary or secondary gain. Now let's look at personality disorders. These are caused by patterns of enduring, inflexible, maladaptive personality traits. They cause impaired social or occupational functioning, or both. They're ego-syntonic, not dystonic. The patients are unaware that they suffer from a personality disorder, and they don't seek help for it. So they're not even aware that they have a disorder. Disorders usually establish in adolescence, and it's often associated with depression, violence, psychotic episodes, suicide. Some of these can cause tremendous stressors in the family. These are family members that just wreak havoc within the family, etc. Pretty common, unfortunately. Up to 20% of the population meets the criteria for personality disorder. The patient, importantly, has to be over 18 years of age to be diagnosed with a personality disorder. So a lot of kids will present with some of this behavior, but it's not until they're 18 that they really can be diagnosed with this. There are 10 types of personality disorders, and we differentiate them into 3 clusters. So we're going to look at the 3 clusters here. There are types that don't fall into the clusters. So there's passive-aggressive type, sadistic, sadomasochistic personality disorders. I'm not going to discuss those, but we're going to look at the more common ones here. And that would be cluster A disorders. Say they're generally weird. So they avoid social situations, can't develop meaningful social relationships. They don't have psychotic symptoms, and there's a familial association, though, with schizophrenia. So paranoid, schizoid, and schizotypal are the 3 cluster A personality disorders. Cluster B would be the wild type, and that's emotional lability, dramatic, emotional unstable, very high incidence of substance abuse and mood disorders, and here too a genetic familial relationship. This is the antisocial, borderline, histrionic, and narcissistic personality disorder. And cluster C are the worriers, and that's the anxious, fearful type, high incidence of anxiety disorders, and this would be the avoidant dependent obsessive compulsive. So looking at this from a Chinese medicine perspective, we can almost begin to tie in different organ processes with this. So for example, the earth types may be more the cluster C personality disorders. The types that are more wood types or fire types, more the cluster B. And the cluster A may be more the metal types in this sense. So I do find that this is one approach we can take clinically when we identify a personality disorder in the patient. Again, they're usually completely unaware of it, but it's something that can help guide our treatments in terms of directing therapies towards an organ or an organ process. Let's look at cluster A here first. That's the sort of the weird type. So the paranoid personality disorder, schizoid, and schizotypal. So paranoid is distrustful, suspicious. They believe others are plotting to deceive them. They're very sensitive. They're quick to interpret events or remarks as threatening. Emotionally distant. And then they don't have fixed delusions, and they're not psychotic. And typically a combination of psychotherapy and antipsychotics are the medications used here. Again, they're not psychotic, but this we think involves dopamine, and that's what these medications treat. Schizoid personality disorder are the loners. They don't have a desire for close relationships or sexual encounters. They choose to engage in solitary activity. They program on the computer or play video games all day, alone in their room. They're indifferent to others. They avoid contact. They have a flattened affect. They're emotionally detached. There's no magical thinking, which is true of the schizotypals, but they might have fixed delusions or psychosis, like in schizophrenia. It's a little more severe, schizoid personality disorder. Psychotherapy is the main approach given for this. And then schizotypal personality disorder is similar but less severe than schizophrenia. So that's odd thought patterns, behavior beliefs, we would say magical thinking. So a person has these incredible beliefs that don't really jive with reality that closely. Some of this happens in some of the people who are really into conspiracy theories and whatnot, and that's a very general statement, but I have seen that patients who constantly bring up this kind of conspiratorial kind of environment might tend more towards the schizotypal personality disorder. They have paranoid ideation, inappropriate affect, very high suicide rate, 10% the lifetime risk. People avoid these types. So usually the paranoid person avoids people, but people avoid the schizotypal types. They're not grossly psychotic. Here, again, low-dose antipsychotics and psychotherapy are the main treatments that are given. Cluster B personality disorders, the wild types. The classic one here is the borderline personality disorder, BPD. And this is diagnosed on the basis of, one, a pervasive pattern of instability of interpersonal relationships, self-image and affect. So they usually have gone through lots of relationships. It's very difficult to maintain, or they're very, very fiery, almost violent kind of relationships. Marked impulsivity usually begins early in adulthood, presents in a variety of contexts, and there's at least 5 of the following. So frantic efforts to avoid real or imagined abandonment. That's a big one. Patients feel like they're going to be abandoned by everyone. Pattern of unstable, intense interpersonal relationships, alternating between idealization and devaluation. So they fall in love with a person. This person is like the greatest thing in the world. And then 2 weeks later, no, this is the worst person in the world, and I don't want to have anything to do with them. Markedly and persistently unstable self-image or sense of self. Impulsivity in at least 2 areas that are potentially self-damaging. So spending, sex, substance abuse, reckless driving, binge eating. Recurrent suicidal behavior, gestures or threats, or self-mutilating behavior. Affective instability due to marked reactivity of mood. So very intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours, only rarely more than a few days. Chronic feelings of emptiness. And there's inappropriate, intense anger or difficulty controlling anger. So you usually have these big outbursts of temper, constant physical fights, and transient stress-related paranoid ideation or severe dissociative symptoms can occur as well in some patients. There's usually a family history, so it's 5 times more common in a first-degree relative of borderline parents. That should be parents, not patients. Increased risk in relatives of alcoholics and patients with mood disorders. And history of sexual or physical abuse can play a role. So we suspect that might be a triggering event in some patients. So reading through these personality disorders, we might all begin to think of people we know that might fit these criteria. Again, the important thing to realize is these patients are not aware that they have a disorder, really. The approach for BPD is usually a combination of psychosocial therapy, so psychotherapy, group therapy, cognitive behavioral therapy, pharmaceuticals with the SNRIs probably be at the top of the list, sometimes tricyclics, low-dose antipsychotics for patients with very volatile moods, and here we need to avoid the benzodiazepines. So that is definitely not a medication that these patients, because of their addictive tendencies, should be prescribed. Now, the good thing is the medications are more effective in BPD than in other personality disorders, but I've had many BPD patients, and with the adequate medication, they still were having significant difficulties. So that's borderline personality disorder. The other cluster B would be antisocial personality disorder. They don't conform to societal laws, so this is more criminal behavior. They completely disregard the rights of others. There's no remorse. They're reckless. They just get through life in any way they can. So deceitful, aggressive, impulsive. Usually this can correlate with drug abuse, but sometimes drug abuse can also trigger a similar phenomena, so that's not a personality disorder. That's more a result of the drug abuse. Usually these patients end up in prison, or at least in jail. And then sometimes in psychiatric hospitals. Psychotherapy, very high addiction potential, so need to be cautious with medications. These are patients that often have scared me in the clinic when just the things they say and kind of the lack of conscience basically can be quite unnerving. So that's something to recognize. Narcissistic personality disorder, this is an exaggerated sense of self-worth and entitlement. They're willing to exploit others for personal gain, arrogant, demand attention, lack empathy for others, there's low self-esteem, and they generally want status, versus antisocial patients want material gain or subjugation of others. So the narcissist, it's all about me. The antisocial is it's about power in a certain way, and I want to overpower others. And that's how their ego represents itself. Psychotherapy is usually offered here. And then finally, the last cluster B personality disorder is histrionic personality disorder. And this patient needs to be the center of attention. So they're inappropriately seductive, flirtatious. They use physical appearance to attract attention. They consider relationships to be more meaningful than they really are. So they think this relationship with this person's in love with them and everything. The other person's like, no, I think she's nice or whatever. But the patient overestimates the significance of the relationship. They're unable to maintain intimate relationships, and their defense mechanism is regression. They return to an earlier development phase to avoid conflict. So that's the histrionic personality disorder. Again, psychotherapy is the mainstay of treatment for that. Finally, cluster C personality disorders are more the worry type. So the avoidant personality disorder has extreme fear of humiliation and rejection from others. So they try to avoid interpersonal contact. They feel inferior to others. They actually desire interpersonal contact, but they feel less significant than their partner. Remember that schizoids tend to avoid interpersonal contact. And this differs from social phobia in that in social phobia, the situations are scary, not the fear of rejection. So that's a difference there. Again, psychotherapy, desensitization therapy, and potentially beta blockers for anxiety would be the avoidant treatments. The dependent personality disorder is extreme need to be dependent on others for emotional support. So they're unable to make their own decisions. They need advice, reassurance from others constantly. They have poor self-confidence. They fear being deserted or being alone. And they may tolerate abuse even by a partner to avoid being left alone. So this is primarily managed through psychosocial therapy and different treatments there. Finally, obsessive compulsive personality disorder. This is different than obsessive compulsive disorder. Remember, in OCD, patients are aware of their obsessions and compulsions, whereas in the personality disorders, a person is not aware of their behavior or the fact that there are these obsessions and compulsions. So there's a tendency towards perfectionism, attention to detail, hinders the ability to complete tasks. They are very devoted to work and not so much devoted or motivated by status, but they're actually motivated by the work itself. They tend to be more inflexible. They have a pack rat mentality often, maybe hoarding mentality, and they're generally cold and rigid in intimate relationships. OCD patients have recurrent obsessions, compulsions, and they are ego dystonic. They're not aware of those obsessions and compulsions. Here again, psychotherapy, CBT may be helpful for them to gain awareness. So these all, as you can imagine, can manifest through a spectrum. And so for some, it's really not playing a significant role in their lives. And there's nothing that really needs to be done per se treatment-wise. But when it is severe, it can severely affect their relationships, their work situation, and their activities of daily living. Again, from a more integrated perspective, we might want to really investigate underlying organ processes and how they're involved with these. Finally, here we'll talk about eating disorders. The general features of eating disorders is that patients have a distorted body image. They use different methods to try to achieve their perceived ideal body image. So already we're starting with an inner imagination, and they feel they need to try to meet that inner imagination. The etiology is multifactorial, so social, biological, including genetic, psychosocial issues like a sense of lack of control, history of sexual abuse, all go into the causation of eating disorders. There's three basic categories: anorexia nervosa, bulimia, and binge eating. So let's look at the first here. So anorexia is really the obsession to stay thin. Patients believe they are overweight when in fact they're actually dangerously underweight. So one of the things we always do is get a BMI on our patients. We get our height and weight, and we see where they fall in the normal ranges for BMI for their age and height and weight. They are, if they're dangerously underweight, that's more than 15% below the normal BMI. That is often going to be accompanied by all sorts of physiologic changes, like in women, amenorrhea. That could be a significant sign of malnutrition and different vitamin deficiencies and so forth. They restrict their eating or eat in cycles of fasting and binge eating. And there's two categories. There's restrictive anorexia and binge eating purging anorexia. So the restrictive is fasting plus extreme exercise, and that's associated usually with obsessive compulsive disorder. So these are patients who often they're even into natural health and a lot of those kinds of movements, and they look like skin and bones. They avoid eating. They go to the gym 7 days a week, working out for 2 hours each time. And then they might go through a period of binge eating, and then they'll purge, they'll vomit and whatnot. The binge eating purging and the type is really someone who binge eats, then uses induced vomiting or laxatives and diuretics to lose body weight, plus usually intensive exercise. So restrictive is more on the fasting side, and the binge eating purging is more on the binge purge cycle. Binge eating highly correlated with major depressive disorder and substance abuse. And this overall anorexia affects about 4% of all adolescents and young adults, so huge. And again, there's a real correlation there with social sort of expectations for different genders and so forth. Females are 10 to 20 times have greater risk than males, and the average age of onset again is pretty young, around 20. So if we look at the criteria for anorexia DSM-5, is distorted body image with a body weight greater than 15% below a healthy body weight, and that's usually the low end of BMI is 18.5, so below that. And then often there's obsession about gaining weight, and in females, very commonly there's amenorrhea, lack of menses, lack of a menstrual cycle. The medical complications can be severe, so amenorrhea is one. Electrolyte abnormalities, so decreased potassium, it can be increased or decreased sodium, and that can create metabolic alkalosis. High cholesterol, the liver attempts to put out more cholesterol for calories. There can be cardiac complications with arrhythmias, partly due to electrolyte disturbances, even cardiac arrest, and laxative abuse, especially stimulant laxatives like senna, are associated with something called melanosis coli. And that's where the compounds in senna, the sennicides, but this is really true of all the stimulant laxatives, which includes rhubarb and others. These compounds actually are used as dyes. And interestingly, people that take them over a long period, the inside of their colon turns black. So a physician doing a colonoscopy would see that. We don't think it's related to increased cancer risk or anything, but certainly that's a sign of overabuse of laxatives. Leukopenia, which is suppression of white cell counts. So then a person is much more susceptible to infections, and osteoporosis. So the important thing with anorexia is to realize there are significant medical complications from the very low body weight and the consequences from that. So if the body weight is less than 80% of the normal, we do inpatient monitoring. So that would be a more extreme situation. Usually a combination of behavioral family therapy is helpful, and then SSRIs and so forth might be used to address the depression aspect of that. So that's anorexia nervosa. Bulimia is a distorted body image, but patients usually maintain a normal body weight. So there aren't the serious complications as in general, although there are medical complications with bulimia. This is binge eating followed by vomiting, usually excessive exercise, and then use of laxatives, diuretics, again to try to drive the weight down. So there's two subtypes, the purging and the non-purging type. There is, this affects, again, about 3% of all adolescents and young adults, more common in females, often associated with mood disorders, impulse control disorders, and substance abuse. And usually, unlike anorexia, bulimic patients are usually ego dystonic. They're actually more prone to seek out help versus anorexia patients are not. The criteria are episodes of binge eating, so that's excessive eating within a 2-hour period. The binge eating followed by self-induced vomiting with maybe a really intense exercise, and then use of the laxatives and diuretics. Symptoms usually occur at least 2 times a week for 3 months, and that's the basic criteria that has to be met. And then the way in which the patient perceives self is defined by their weight, and that can be obtained through their history and going through that. Again, we can see electrolyte complications here, decrease potassium and changes in sodium. Again, metabolic alkalosis, cardiac arrhythmias. But the big thing here is dental erosion from all of the acid, stomach acid constantly coming up. The teeth get eroded. The knuckles often look red, and that's from self-induced vomiting. And then hypertrophy of the salivary glands can occur as well. So that's bulimia. The treatment, again, is usually cognitive behavioral therapy or psychotherapy, and then antidepressants might be used as well. So that's anorexia and bulimia. And then finally, there's binge eating disorder, and that's recurrent episodes of binge eating associated with severe stress or distress. Patients are not concerned about preventing weight gain. Often these patients are obese, and so here it's not about eating and then vomiting to lose the weight. It's just about the eating is a coping mechanism for stressors. High risk of hypertension, type 2 diabetes, cardiac disease. So the criteria here are recurrent episodes of binge eating that are not associated with other behaviors, such as excessive exercise. Symptoms are ego dystonic, so patients do feel ashamed. They're guilty about their eating habits. They know they're overeating. Symptoms often occur at least 2 times a week for 6 months, and 3 or more of the following have to be present. So rapid eating, eating when not hungry, consuming an excessive amount of food, and then feeling embarrassed or guilty about their behavior. They tend to eat alone or in secret. That's binge eating disorder. So here really a comprehensive diet and exercise program are important. Psychosocial therapy, maybe to deal with the stressors and what are the underlying feelings that are triggering that. And then the pharmacologic therapy usually is actually, interestingly, stimulants, and these are to suppress appetite. So sibutramine, the Meridia, this is actually works with serotonin receptors and norepinephrine uptake. So That's one example of a therapy may be used for binge eating disorder. So that covers it for the eating disorders: anorexia, bulimia, and now binge eating disorder. And that summarizes it for all of the kind of most common mental health conditions you'll tend to see clinically. There are many others we haven't discussed, for example, addiction disorders and so forth, and that's something you can read about and we can discuss in other contexts. But this will give you the baseline knowledge you need to know when working with mental health issues.